Okay, good morning. I'm very glad to be here with you all today, and I thank the organizers for inviting me and coming to speak. My comments are targeted toward getting us to think further about the ecological model that Eric just ran us through in terms of methodological, conceptual, and some empirical issues that I wanted to draw our attention to. The methodological orientation that I'm bringing to the table here is an anthropological one, and it is the case that we like to think in terms of Homo sapiens and all persons on our very largely populated planet in comparative context and from multiple perspectives, and looking in particular at issues of cultural meaning as well as subjective experience. Cultural meaning is critical to look at insofar as we try to think about questions of the interrelations of mental health, mental illness, and violence, because what does it mean to a person to get or accept treatment? What does it mean for people to get or accept medication? Culture is not the entire story. Economic factors are huge, as are many other, but this is certainly one that in my own research experience has proven important. Now, the kind of research that I and my colleagues have done over the years is always team-based, collaborative research with a mixed group of health scientists and social scientists, and mixed methods. We do usually whatever standardized clinical, whether it's DSM-4 or DSM-5, standard clinical research diagnostic criteria for the psychiatrists who do our diagnoses for us for the studies that we've done, as well as a team of anthropologists who are doing ethnographic work, be that interviewing or naturalistic observation. Basically, for anthropologists, every single thing is data all the time. And my students and family know this to be a fact for me and find it incredibly annoying, but it's a compulsion at this point, which I will never be able to give up.
There are treatments for that.
There are treatments for that. I thought it was psychopharmacological, or I think behavioral I don't know. I'm on California time. I'd be open to a variety of interventions at the moment. Actually, probably caffeine would be the best. Anyway, getting back to the point, we used multiple methods, mixed methods. We get survey data to try to identify those variables for which we can find some significant action going on, and then try to look further into those same variables and factors for specification of those in terms of social, cultural, psychological, etc. And we are always trying to get perspectives from multiple actors, or we could say stakeholders, with patients, their kin or family, healthcare providers, local policy officials, and as much as we can. So here's what I have to say to add to our thinking about the model, which is that culture, and I'm going to talk about it, crosscuts overlapping sectors of the individual social relationships and the community and societal dimensions that Eric has in several particular ways. But we do have at this point now from transcultural psychiatry, as well as a lot of work in medical anthropology, several decades to show the centrality of culture to mental health and mental illness. And it is more on the mental illness side than health, but hopefully we will get better at studying and learning more about mental health and well-being. But at the moment, we certainly know about risk and vulnerability factors, such as gender inequity, and symptom content and form and constellation. These are hugely variable cross-culturally, and the significance of this is that what's in one's head, if you're having voices, makes a difference in terms of what you might do. So the reflection of the broader society in terms of preoccupations with what gets taken up thematically matter. So a lot of times we don't pay that much attention to content. We just, the symptom's there, it's not there, we need our diagnostic criteria met. However, I'd like to suggest that we might want to pay more attention to that. And we do know that transnationally, from the WHO studies of the International Pilot Study of Schizophrenia, that there really is tremendous variation in terms of form, auditory or visual, olfactory, et cetera, types of hallucinations and the constellation of those and how those tend to go together. Clinical diagnostic process is pretty clear in terms of cultural factors that go into that. I'm sure everyone is aware here. Illness experience in terms of the identification, and here by identification I mean when persons or patients themselves and or their kin or neighbors determine that there's a problem, there's something wrong. How does that get defined? How does that, is that thought about? What sorts of treatments come to mind and are utilized? And the explanatory models and the meaning of what the cause is, what the likely course and outcome is, are really, really important. Anthropologists have been interested in this for its own sake for a long time, but it's critically important. Oops, went back. It's critically important to my last and favorite factor that I have listed here in terms of what culture shapes course and outcome. To put together a couple of these things that I have here on the slide, kin emotional response, whether people are hostile, whether they are critical, excuse me, or whether they are sympathetic or warm, is contingent entirely on what kind of problem they think it is. If they think that it's a problem of a personality defect, they're lazy, they're no good, that's going to have one kind of pathway in terms of emotional response. If they think that it's a legitimate illness for which sympathy and treatment is required, that's another. These factors make a big difference in what I think we almost all care, certainly I, most about who gets better, who recovers, what makes a difference. So what's involved in culture and conceptualizing it? Subjective orientations and awareness of the self. The self is not constituted or experienced the same way worldwide. There's variations in how individualistic or self-centered the self is versus sociocentric or more other-oriented, and that's an important factor. Assumptions about the world and one's place in it, definitions of social worthiness, the repertoire for emotions understood as aspects of cultural systems or moral and ideological attitudes, understandings of what's acceptable behavior and what's not, basically the cultural rules. Now, one example I can give you cross-culturally comes from a study, the first ever to look at conceptions of psychosis cross-culturally in 4 East African societies by Robert Edgerton. He asked, it was a large survey study, and he asked people to describe what the behaviors of a psychotic person were. And the top vote getters were, this is a microscopically small font here, so I'll try to give you a quick rundown on it. What they found was that what concerned people the most is, in terms of social disruption, were murder, assault, disruptive behaviors. Turns out, I think, rather unsurprisingly, these are cross-cultural deal busters. People do not tolerate violent or disruptive behavior and are quite concerned about it. And these data show both a kind of universality to the conceptions of mental, conceptions of psychosis, as well as some cultural specificity. But moving along quickly, my time is going. How can the concept of culture broaden our understandings of violence? We know that in developing countries, we have high homicide rates, although much of Asia has lower rates than its developing peers. And the US, of course, has higher rates than its other comparative high-income countries. The highest dark red hotspots here are El Salvador, Guatemala, Belize, Honduras, Jamaica, Cote d'Ivoire, Zambia, and Malawi as the highest in terms of those homicide rates. And we just ask ourselves, what's wrong with this picture? Violence is not uniform transcontinentally. There are cultural factors, but it's not all cultural. There are socioeconomic factors, but that's not the whole story either. There are some regions that are besieged by complex cultural, economic, and political disadvantage. So another way of thinking about violence has to do with the factors that I have listed here that go to issues of subjective dimensions of violence as well as objective ones, and particularly structural arrangements. This is a concept of structural violence that has been written about by my colleague Paul Farmer. Where are you? There, a physician anthropologist at Harvard, and try to look at what broadly, systemically, directly and indirectly exert influences that cause harm or violence, disadvantage individuals. Ethnocentrism, racism, sexism, and poverty are certainly good examples of this. And it's very important because this seriously constrains individual agency. Now, this is a concept that I had developed, political ethos, that comes really as an extension from Gregory Bateson. Gregory Bateson, anthropologist, famous mostly because he was married to Margaret Mead. She's also quite brilliant theorist, but he developed this idea for a small tribal society, but in trying to extend it out to contemporary circumstances, I have thought about this in terms of social domains of power and interest. Now, I'm going to talk very briefly. I cannot believe, I think this clock was set 5 minutes less than I somehow was prepared for. Nonetheless, this study that we did in the Cambridge Hospital of the Latino clinic of the Cambridge Hospital at Harvard Medical School was really quite interesting in showing the kinds of problems that are seen by refugees who have fled horrendous political violence, and some of the kind of interesting symptom pictures that come up in response to that. And we had identified some as calor, or the feeling of intense heat that was commonly being presented in the emergency room. And very quickly, what we found was that even though these particular patients were, by diagnostic criteria, suffering from both depression as well as PTSD, they were working in almost 2 jobs, typically working 60 hours a week in vigorous efforts to make as much money as they possibly could to send home to their families. And it raised the question about a certain kind of engaged depression that we had not seen. And it really brought home tremendously the importance of resilience and how this can be amplified by the right kinds of therapeutic as well as cultural and legal systems to support it. I'm not going to be able to tell you too much about this study, but the Southwest Youth Experience of Psychiatric Treatment is a study of adolescent mental health, in which we have found almost all of the factors that Eric had on the risk factors. If you take a look at that chart, you will find a description of the adolescents. This is Sortrese, one of the gangs that is in the area. And this is the Children's Psychiatric Hospital. And I've got, this is excellent because, oh, I wasn't so bad on time as I thought. This is the last bit of this. And because these are preliminary data, I can only give this to you somewhat orally. But just to say that major depression is, these are the KID-SCID diagnoses, and the findings that we had from that show that these are the biggest vote getters and very commonly diagnosed, as well as often comorbid. And finally, last thing I wanted to show you is that we have these ethnographic data that we analyze in total, and we try to identify what were the most common themes that were emerging that the kids were really preoccupied with. And 6 out of 8 of these were violence related, with the exception of bereavement or alcohol use and alcohol abuse. And this was really quite striking in preparing to come to this meeting, to see the reflection of the broader situation theater of structural violence and the subjective experience in terms of what people are preoccupied with. Perpetrators of violent acts, there really weren't any gender differences. 75% of girls and boys were involved with these violent acts. Suicide, 68%, and encounters with the police were about half of the girls, or 4/5 of the boys. Victims of physical abuse, half of the kids, both girls and boys. Sexual abuse, 1/3, but higher for girls. And self-cutting, twice as common for the girls. So with that very quick conceptual, methodological, and empirical infusion into our discussion, I look forward to more. Thank you.
Thank you, Janis.